So, good afternoon, everyone. I'm truly honored to be here. It's a mega event, and I love all the teamwork and interactions that's going on between everyone. I'm Aya Shekhani. I'm a professor of phoniatrics, Cairo University, and I've been working in the CI field since 2006. I'm very lucky. I've been working with a full team, and it has been a lot of work and a very big journey. We advocated for a very long time for the pediatric CI, and now we are really in the journey of advocating for the elderly because they really deserve a chance for quality of life. I'd like to thank Professor Dr. Badr Mustafa and Professor Dr. Nirvana Hafiz for their kind invitation. I'm truly thankful. And I'd like to welcome my dear panelists. Professor Eric, I think he's on his way. And I'd like to welcome Professor Dr. Amira Shenawi. In my humble opinion, she's one of the best audiologists in the CI field, not only in Egypt, but in the Middle East and North Africa. Professor Dr. Nihal Hisham. Oh, here you are, sir. I was just saying that we're waiting for you. We're truly honored to have you with us. Thank you. And Professor Dr. Iman Ruby. Me and Iman, we have a very long journey together in the CI field and the rehab as well. So, geriatrics. What we all wish for is to age as gracefully as these are aging. However, this is not always the case. We have the normal aging and we have the dementia. And dementia, according to the WHO, is the most devastating and malignant disease affecting the elderly. It's even more devastating than cancer. So aging can cause many breakdowns in communication, emotion, nutrition, physical, financial, and cognitive. The aging population is expected by 2050 to reach 20%. We are an aging world, okay? So we have to keep this in mind. The aging brain is just like the seasons. You lose part of your actions and your leaves just as you lose it in the seasons. Cognition in the elderly, you can get the resilient elderly where they have no cognitive breakdown, and you can get the ones with severe dementia. It's a full spectrum. No one is the same like the other. Communication and cognition go hand in hand. So if cognition is affected, communication is affected. If communication is affected, cognition is affected. I will present the opposing side against CI in the elderly, and I would love my dear panelists to tell us their experience and science. With or against, that's okay. We will just want to discuss together. Is it truly risky and dangerous, as many, not only people, but professionals as well, still advocate against CI in the elderly? So the first question goes to Dr. Amira Shenawi. Disabling hearing loss is not common among the elderly. They learn to live with it. Then why would we advocate for CI?
Actually, I'm totally against this. I'm with if the patient is for anesthesia, they approve of him having a surgery. And if he's a candidate for CI surgery, then of course there is no upper age limit for cochlear implantation. And hearing loss is disabling and it affects the elderly so much, and they do not learn to live with it. And if they do so learn to live with it, it affects them in other ways, and we see that a lot. I'm not going to talk only about bilateral severe to profound hearing loss where they would need a cochlear implant, but also if they have lesser degrees of hearing loss and they need hearing aids. Sure. We see that in all the audiologists in our everyday practice. We have the elderly patients, most of them, they do not acknowledge their hearing problems. They come with their families who push them to have their hearing aids, and we do counsel them about the effects of the adverse effect of hearing loss on not only on their communication, because it's related, of course. I'm not sure if we're going to discuss that later on. Okay, yes. But it's all related. They can go into cognitive problems and dementia and we can overcome this if we use hearing aids early on. And
So-
of course, if they are in need of cochlear implants,
Go
I'm
ahead and do it.
totally with having
I really want to highlight the point of early on because we're going to discuss it later on. And this is what, just exactly as Dr. Amira was saying, this is what the science has to say. It's not the years, it's years lived with disability. This is now how they measure the years lived. It's not just years. So it's not just I'm having 5 more years, 10 more years. It's the years lived with disability. And in the elderly, 70% of the elderly adults have degrees of hearing that are affecting. It's not just learning how to live with it. No, they don't learn how to live with it. Hearing loss is a natural phenomena and doesn't affect cognition. What do you think of this, Dr. Iman? What do you think of this statement?
Hearing loss, of course, I think affects cognition. If the patient, the elderly, is deprived of hearing, with time, he will have some cognitive impairment, either memory, executive functions, and mental health. And this will affect him later in his social interaction with
True.
the people around him, either his family or even in his career.
This is absolutely right.
So it does affect cognition, but there is a correlation between cognition and, because some patients, they already have elderly, they already have mild
Cognitive impairment. Exactly.
And then this is associated with hearing loss, but definitely hearing loss will lead with time to
Magnify the problem.
Yes,
It will magnify the problem,
especially
and this
if
is
it's not corrected in a proper way.
if it's not aided, not implanted,
Yes,
not whatever,
most
just left
of the elderly,
untreated.
they start by hearing aids, and unfortunately, because they are not they're not they don't
Complaining,
feel,
they're just dealing with
they're
it.
not compliant to these hearing
Exact.
aids because they do not provide them with what they expect.
We're going to discuss the compliance. So this is exactly what science has to say. So hearing loss does not affect only communication. It affects cognition, mental health, memory, finances, and educational access as well. So effect of hearing loss and cognition is a decline on all the aging brain. It's not just communication breakdown. You have always to keep this in mind because it's one of the major causes of depression as well. So depression also leads to profound dementia and to increase the rate. So hearing loss and dementia are always going hand in hand. Mild hearing loss causes 2 times increase in the rate of dementia, moderate 3 times, and severe reaches up to 5 times in magnifying the problem of dementia. So, how can CI be a solution for cognitive impairments? That's the question that a lot of people ask. Why are you talking about his cognition? I was faced with this in one of the committees for CI. Aya, why are you talking about his cognition and we're talking about his hearing? So what do you think of this, Dr. Nihal?
Hearing is directly and positive, significant. There is a positive, significant correlation between hearing and cognition.
So,
if we talk about the peripheral hearing, it's strongly related to the global cognitive abilities of the person. If we're talking about the central auditory processing, it's related to the attention, concentration, the memory, especially short-term memory, executive function, the ability to processing newly information or processing any information in general, and the working memory. So hearing loss, whatever its cause, it's peripheral or central, both affecting cognition.
this is right.
By many theories, and maybe because of cognitive resources allocation. They use their resources in concentrating in what we hear, leaving a few resources for higher processing in the central nervous system.
So when they have proper access to sound, this would improve,
when you
right?
have a good quality to sound
بالضبط.
perception,
بالضبط.
even preventing the
The decline.
structural and
صح.
functional
Decline.
dysfunction for the cortex.
صح.
Also, if he has depression, it affects directly the
صح.
hearing and
True.
the cognition, and influence the process and augment the cognitive impairment.
And just as
So
Dr.
the
Amira was saying, the early intervention.
yes,
So it's not
true.
even
I want
waiting
early
too long
intervention.
and then coming and say, let's put the CI, and it's already too late, but we want to do it as early as we can. Exactly. Okay. Professor Eric, I'd like to ask you about this, and we have lots of questions for you regarding the surgery as well prepared. So the need for hearing is much less in the elderly. How would you judge this statement, particularly in your culture, in your country? What do you think about this statement?
In France, there is different problems according to acceptance of hearing aids in elderly. First is psychological, because
Exactly.
when we prepare them to having any hearing aid, they assimilate this proposition to the decline in aging.
Exactly.
And because there are some aesthetic problems,
Yes.
and so we have sometimes very big difficulties to make it accept
That's
by
right.
the elderly. But it's a pity, because we don't know that it was said that early intervention is very, very effective.
Exactly.
And actually it's proven that it could help to reduce
The cognitive decline. Exactly, exactly. This is what we say. So hearing is very, very important to maintain communication and avoid social isolation and all the cascade of what will happen from the social isolation. So this is exactly. So the science is saying this. It's not how long they live. It's the dependency, the health, their critical and their material circumstances. And really, it's very, very important to know that hearing is one of the disabling things that we can prevent. We have other disabling diseases that we cannot prevent in the elderly. So we have to think always about that. And the next question is also for you, Professor Eric. Surgery is quite risky in the elderly. And this is we get to face a lot from families and from professionals as well. So what do you think of this statement? Is it true? Is it not true? What do you think of that? From your experience.
Okay. Surgery is ever a difficult moment for a person.
It's risky for everyone, exactly. It's true.
But it's much more important in the elderly, because they have sometimes bad conditions, because we can face some difficulties with anesthesiologists.
True.
And the problem is to evaluate this person with a gerontologist.
Yes.
And with a general practitioner.
Exactly.
And to have a common decision.
So you have to make yourself sure of everything.
Yes.
Yes.
And also with a cognitive factor, but it's only about surgery here.
Yes.
So surgery is at risk in the
And I know that you have quite, you told me that you already have a population of elderly that you already implanted. Yes. So was it that risky in them? Or was it the common complications just as, or close to the other adults that implant?
Okay. We have done a recent work about a series of 36 patients over 80.
Perfect.
Which is old.
Mm-hmm.
We selected over 80 because it's a very...
well, it's a very big number, yes, of course.
Yes, of course. And what we observed in terms of surgery and risk was two things. We have one patient with deterioration of health status because some
cardiac
heart
yes,
problem
cardiac problems.
Was resolved. And second, we have some 3 patients with delaying outcome from the hospital because of vertigo.
Okay.
And I think it's very important to consider
vertigo, balance, yes.
Balance
yes.
before surgery.
Sure, sure.
Very important.
So, according to many studies, and I wanted to list many studies here, so they have shown that CI in the elderly is well tolerated and that the risks of major and minor surgical complications are equivalent to those at the younger ages and adults. So it's not very, very risky compared to them. The hearing aids are equally effective in the elderly. This is my question to you, Dr. Amira. What do you think of this statement?
Do you mean that they get the same results?
Yes, exactly. They're equally effective, so why put them to surgery for CI if this is one of the statements that we also get very commonly, particularly for elderly. So what do you think of that?
Actually, it's a CI candidate, being an elderly or pediatric, is not is a CI candidate,
so he's not
does
benefiting
not benefit from his hearing aid.
Thank
so
you very much.
Equalize
exactly.
the benefits. If he's doing well with the hearing aids, then we will never opt for a cochlear implant.
And correct me if I'm wrong, isn't the speech discrimination in the elderly is not directly proportional to the hearing loss level? So they could have like moderate hearing loss, but still they can have very poor speech discrimination?
Exactly. The speech discrimination is effective more in the elderly during to reduce temporal processing abilities.
The cognitive and executive
And-
functions
exactly.
and auditory process.
So what we have to do when we fit them with a hearing aid or a cochlear implant is that you have to counsel the patient very properly about what to expect from either
Exactly.
methods, and that both the cochlear implant will improve his speech discrimination abilities definitely, but you have to lower his expectations, or they have to have realistic expectations about what to expect, and you have to tell them also about the risks of not having a hearing rehabilitation, whatever, with hearing aids or with the cochlear implants,
Exactly.
that they have that the speech discrimination can be further reduced, and they can go into social isolation and depression
exactly.
and so on, and
Exactly.
reduced cognitive ability.
So this is exactly what science has to say, and just as Professor Amira was saying, and in the many studies are now working on that, and there is a huge discrepancy between the use of CI with a hearing aid versus bilateral hearing aids. So even bimodal fitting is even much better than even only the CI. Dr. Iman, the elderly will refuse the CI and become a non-user, just as we have a lot of non-users with the hearing aids. What do you think of that? What do you think of this statement?
Do you mean that he tried the
Yeah,
hearing
we
aid?
will have the surgery, we will have it on, and then he will just remove it and not use it. He'll become a non-user for the CI, just he is a non-user for the hearing aid. What do you think of that? And it's
Well,
quite an expensive device to not use,
yes,
so.
yes. Well, I think that we should deal with the elderly like adults and children. The problem of the CI is that they hear by a different way, electrical stimulation.
True.
It's not acoustic
True.
stimulation.
Correct.
So we have to give him counseling that auditory rehabilitation is essential after the CI, because it is important that he not only hears, he has
He needs
to
to listen and
understand.
understand.
Speech
True.
perception and speech understanding is very important,
Yes.
and listening by his CI is very important. So I think if the patient is not auditory rehabilitated after CI, he may refuse the CI, and it may be its fortune would be like the hearing aid.
I totally agree, and I think that there are two reasons for elderly to refuse to wear hearing aids or CIs. One of them is social, so
Yes.
we can never work with that unless we counsel. But I think that one of the major causes of the non-use of hearing aids is that they don't have proper access to sound. So you're still having me put a hearing aid, and I still don't have proper access.
Yes,
So with just as Dr. Amira is saying, so if he is a candidate for CI, so if he gets this proper access and he feels less social isolation, better communication, the researchers are saying that they are better in hearing the CIs rather than the hearing aids. So yes, it is.
he will accept it.
They will accept it. They have better access to sound, so they actually wear it most of their awake hours. And I have my patients like this. They actually look for their CIs, and when they're not working, it's a very big problem for them, because always remember that also elderly, many of them live alone. So access to sound is very, very important. So the cost is too much for the benefit acquired. What do you think of this, Dr. Nihal? What do you think of this statement? That the cost is too much and they're elderly, they're not going to live for so long, and the words that we always hear, and we hear a lot in the committees.
I think it's worth it to get CI. CI improves the patient communication, perception, speech perception, and speech discrimination, especially in noise, especially if his job depending on communication and interaction with others. It improves his self-confidence, his self-image. Preventing many problems like withdrawal
and having to go back to neurologist and psychiatrist and paying all this money.
In initiating conversation or in maintaining communication with others. So when he do CI, he will benefit, sure.
Yes, actually in numbers, this is one of the researches that was done in 2021, and these are the numbers. So adults and seniors with progressive profound and sensory neural hearing loss will have a net benefit of 2,750,000 euros and 76,000 euros. So actually the adults will benefit more, yes, than the seniors, but still the seniors, 76,000 euros is much more expensive than the CI cost itself. Because you're preventing going to doctors, having medical problems, falling because he's not listening, he's not having everything, advanced dementia and having to go to hospice and having to go to hospitals and ICUs and everything. So the cost eventually is much better for the CI than it is for the dementia itself. So, Professor Eric, the life expectancy for the elderly is too short for this expensive implant.
It depends, inshallah.
Exactly, it depends.
Nobody who knows the term of the life for this person or this person.
Exactly.
Sometimes some elderly seems to be in good condition and they will die in 2 years.
Exactly.
And someone have to be less health condition and they are
Lives
living
longer.
for so long.
Exactly.
So there is a sort of a deal. It's like a gamble, finally. I think we don't have to make any speculation about that.
Of
if
the
the
age.
patient is a
Exactly.
candidate, we could consider him, and we hope it will be a good.
You know, I was presenting this panel in Abu Dhabi just last month, and Professor George Prenzel from Austria, he said that he implanted his aunt at the age of 80, and she lived 5 to 7 years of very healthy life and communication, and that he was very sad that he didn't implant his dad. And he went into the dementia, and now it's too late because he's already in advanced dementia to implant. So he said those 5 or 7 years are very, very important, and everyone was very happy to have them, even if they're only 5 or 7. And now it's too late to implant his own father. So I remember this statement when I was just saying the same about the age. So actually, it's not about the life expectancy. It's the years of life lived with disability and the years of life lived healthy. So it is very, very important to think of this. It's not about living longer. It's living healthier with better quality of life. So CI is contraindicated in the elderly because of dementia. Dr. Amira, what do you think of that?
Well, actually, that's a tricky one. And I've never come across a case that has dementia and came for asking or their parents, children coming asking for their parents' implantation. I wouldn't recommend implanting a patient with dementia because according to the stage
To the
of
stage,
dementia,
yes, because I'm going to tell you
yes.
about a patient that we
Yes.
had. Yes,
But
exactly.
even if it's mild dementia, you are not sure that it
Exactly.
will not
Early
progress.
stage.
Yes.
Yes.
And you know that the patient will not be able to take care of his implant, or the cost effectiveness would not be
In
that
advanced
great.
stages and moderate, yes, and even the researchers go with this, not implanting in this.
Yes, actually, we do try to prevent dementia by implanting.
This is exactly so. Early implantation is very, very important. The importance of early implantation, not the late one. One of my cases, he was 63 years old. He had 3 recurrent strokes because of an autoimmune disease, and he developed vascular dementia. But he was in the very, very early stages of vascular dementia, and he lost his hearing because of his autoimmune disease. He was living alone, and he came to one of the committees in the hospitals that I work in, and he would be fully funded by his insurance. And actually, we had a lot of debate, a lot of people were against, people were with, but honestly, me and the surgeon were with definitely, and he did it. And Dr. Iman Abdel Badia was the one doing his programming. He heard from the first setting, from the switch on. And but I didn't put the video for that. And I saw him 6 months later. He is very happy. According to his neurologist, his status in the dementia is the progression is almost non-remarkable. And he's at least independent. His daughter lives abroad, so he needs his independency and safety at the same time. And he was talking to us when he was switched on. So this was absolutely amazing. So the importance of early intervention is very, very important. 40% of dementia cases could be preventing by addressing the cause. And if the cause is hearing, so let's go ahead and address it. So this is what science has to say. CI really significantly improves the quality of life in the elderly. Just keep this in mind. So to wrap it up, an elderly population, really, they need to be loved and cared for. No matter what is the problem, it's dementia, it's hearing, it's communication. It's just having them turn into little babies once again that you have to take care of. We switch roles in the elderly. So I would love to thank my dear panelists. It was amazing to have you all. Thank you, dear audience, and thank you.